and then the time of exposure of every letter, and then the area of retina stimulated. Maybe you guys wonder what is the area of retina stimulated. So this one, you guys can imagine patient with screen that has, like whether it is convergent or divergent screen. So the later, any source of light or any test object, it will fall not on the retina because because the eye is deviated. Why our eye need to be in autophoric position, means tak ada screen lah, tegak dua-dua mata, is because for any object, for any test or for any light to fall directly onto the fovea. But if the eye is diverging or converging, so the image will fall on the other part of the retina, not on the fovea. And then the state of adaptation of the eye movement. The eye movement ni macam patient with nystagmus. Okay, maybe sebelum, kalau memang lahir dengan congenital nystagmus, this patient tak akan ada complaint of macam nampak dancing object ke apa semua. But if the nystagmus develop later, perhaps at the age of 15, 16 or 20 plus because of any medical condition, so it will affect the visual acuity and the cognitive status. We don't do visual acuity in patients that has low GCS. Okay. Alright. Okay. These are another factors which can be divided into stimulus-related factors and the observer-related factors. So it is actually about the same but a little bit detailed. So the stimulus related to depending on the test object or the light. Okay, the observer related is the patients. Okay, so on the observer related factors here, I include also accommodations and meridional variation. This sama juga macam yang screen tadi. And then the optical elements. Optical elements means the state of the cornea and lens, because cornea and lens is part of the optical elements of the eye because they're transparent and it will allow the light pass through. Other than that, the developmental aspect of the patients, okay, or the subjects, and the retinal locus of stimulations, mean which are the area of retina being stimulated. So what are the components of visual acuity? So bila kita cakap, if I say visual function, when we say visual function, kita macam, it's like testing the cranial nerve too, second cranial nerve. So which means kita akan check the visual acuity, the RAPD, the relative afferent pupillary defect, the color vision, etc. lah. But when we talk about the visual acuity, which is part of the second cranial nerve function, okay, ada few components under it. Okay, so we will go one by one. The first one is minimum distinguishable or minimum visible. This is actually the ability of the eye to see something as being distinguishable from the background. So you all boleh nampak tak ada small dots dekat tepi ni? Okay, I ada buat one dot, small dots at the side of the box. So ini nak tunjukkan yang the ability of the eye to see that ada something yang distinguished from the background. Okay, so it depends upon the specification of the stimulus, such as the size and the illumination, and it's actually macam detection of black dot against white background ataupun visualization of telegraph wire against a uniform sky. Okay, the second component, the first one is minimum distinguishable. Second one is minimum separable. So the ability of the eye to determine a group of points or lines as separate and distinct. Okay, those who has, I'm sure every one of you has good vision. So you can see the lines on the gratings tu macam separated lah. Like black and then white, black, white, black, white. But those with poor vision, they will see this one as one blackish box macam tu. Dia akan macam kalau nampak tengah tu putih pun dia macam like very blur. Okay, so means the visual acuity is slightly reduced. But those with good vision, they can see this one clearly. So so this is actually the measurement of threshold of discrimination. Essentially, it is an assessment of the fovea centralis means the fovea center of the eye. Okay, and it is termed as ordinary visual acuity. So this concept, the gratings ni kita use for the Snellen chart, Landau chart, gratings, etc. lah. Okay, walaupun Snellen chart adalah huruf, but you can see E, if letter E, even letter G, letter O, ada certain part yang hujung-hujung dia terpisah kan. So this is the things yang kita tengok the minimum separable function of the eye. Okay, the third one is minimum recognition. It is the ability to form sense or minimum legible, which is form sense ni macam kita bagi Landau C. Kita guna huruf C saja, tapi C tu kita terbalik-terbalikkan. So kita nak tengok the patient boleh, when we assessing the visual acuity, kita nak tengok dia dapat tak nampak C ni, bukan huruf C, memang everybody can see the C later, but where is the open one. C kan ada gapping kan, the gapping tu dekat mana, ataupun the minimum legible in which we can use any letters or numbers. Okay, alright. And it is if it is difficult to assess, let's say patient is macam illiterate atau memang tak faham the instruction, kita boleh ask the patient to identify faces. So faces is the macam tengok muka orang lah. Tengok muka, nampak tak hidung, nampak tak mata. So this is the most common example of recognition. And the last one is the minimum discriminable or hyperacuity. So it is the best example. The best example is the vernier acuity, in which it refers to the ability of the eye to determine whether two parallel straight lines dia align together atau tak, dia bersambung atau tak, macam tu. So you can see from the example in the box ataupun the gambar kat tepi yang dua parallel line tu lah. So those with 6 vision, very good vision, even like 6-9 also can still see that it is separable. Okay. Okay, so the threshold values of this vernier acuity are in the range of only a few seconds, 2 to 10 seconds of arc. Okay, what is the standard test distances? Maksudnya macam how do we assess the visual acuity? So we have two standard test distances, which is distant visual acuity and the other one is near visual acuity. So this distant visual acuity is a must for everybody to know. The near visual acuity, it is a supplementary in which kita akan assess in those subjects age more than 35, like 38 nearing to 40, because they will have some reduce in accommodations, and as well as in perhaps pediatric patients that has undergone cataract surgery. So those without natural lens, I mean already undergone cataract surgery, already implanted artificial lens, we can't, they can't accommodate anymore, okay, because the lens dah tak ada berubah, dia hanya one piece of artificial lens, so we need to do near visual acuity. So we go one by one. The distance ones we do at 20 feet ataupun 6 meter, because this is equivalent to optical infinity. For near visual acuity, I put here 40 cm, but it's actually dependent on the nature of the subject's work or subject task. Some they prefer to read or to do tasks, the near task at 25 or 30, so we will do at that distance. And this distance and near visual acuity should be tested separately. Okay, how to test for distant visual acuity? The patient will be seated at 6 meter distance from the Snellen chart. Okay, so that the rays of light are practically parallel and patients will exert minimal accommodations. Sebab kita tak nak patient accommodate. Whenever someone accommodate, obviously the vision will be slightly better. Okay, we don't want that. So we put the patient at 6 meter distance. This is optical infinity and lights will go parallel to the eye. Okay, and the chart, any chart that we use, whether Snellen chart or we have other chart in the clinic, you can go see at the room 17 or room 19 in which we use belly level chart, and then this all the chart should be properly illuminated. patient is asked to read the chart with each eye separately. Okay, first we do on the right eye, then left eye. Okay, but it depends. If the right eye already very poor, sometimes we want to do on the left eye first. So this is very subjective. Okay. Okay, so how we do that? We will ask the patients to read from the topmost line from 6 meter. Okay, if can see, then we will ask further down, means to the smaller letter. But what happen if the subjects or the patients cannot see the top line from 6 meter? We will ask the patients to slowly walk 1 meter at one time. Okay, so I will explain later after this. So for the standard visual acuity test in preschool or school going children aged more than 5 years old and adults, we will use standard Snellen chart. This is a very easy to remember that for you guys to know, we use Snellen chart. This Snellen chart has been developed long time ago, since 1862. Okay, because the basis of this Snellen chart is actually two distant points can be visible as separate only when they subtend an angle of 1 minute at the nodal point. So we are testing this angle at the nodal point. Alright. So there are many types of Snellen chart nowadays, but it's good to know that the traditional Snellen chart is printed with 11 lines of block letters using the 10 Sloan letters C, D, E, F, L, and O, P, T, Z. Okay, this is the standard in the traditional Snellen chart. But nowadays, dah ada banyak variation lah. Okay, so alright. Okay, this is the example of the Snellen chart. So if looking from the topmost is 660. What is this 660 means? Okay, so we look at the 6 meter, the number 6 refer to the distance that the subject can see. The 60, the yang bawah tu, the fraction bawah tu, it refers to what a normal eye that has no pathology can see. So if the patient can see, if the subject can see at 660, means if a normal eye can see this letter at 60 meter, but the tested subject, the patient sekarang ni cuma dapat tengok dekat 6 meter. Okay. And then, okay, kalau tak faham, kita tengok dekat 612. Okay, looking at 612. At 612 mean, and the letter in normal person that can see this letter at 12 meter distance, but the current patient that we are testing, dia cuma nampak dekat 6 meter. Means the vision is poorer than the normal subject. Okay, so okay, itu adalah the definition lah. Alright, so bila kita nak write down the finding, the visual acuity, the topmost, the numerator will be the distance of the patient from the letters, and yang bawah ni, denominator being the smallest letters accurately read. Okay, means the line yang kita tengok tadi tu lah, macam kat sini. Okay, 636. Itu just menunjukkan this line, tapi the meaning of this line, macam I mention tadi, in normal patient, in normal subject, they can see this letter, the letter Y and O at 36 meter, tapi the patients can only see at 6 meter. Okay, so depending upon the smallest line, which the patient can read from the distance of 6 meter, the vision will be recorded as 69, 66, 69, 624, 636, and 660 respectively. Okay, just now I already tell you, if the patient cannot read the topmost, so we will bring the patient forward 1 meter at one time, and then the vision will be recorded turun lah. Dia dah tak nampak dekat 6 meter, so let's say the patient can see at 5 meter. After dia gerak selangkah, 2 langkah lah untuk dapat 5 meter tu, so the vision is 560. Okay, then kalau tak nampak juga, bring forward lagi sampai lah tu 160. So what does it 160 means? Okay, in normal patient, in normal subject, they can see the letter at 60 meter. From 60 meter boleh nampak dah huruf tu. Tapi the current tested subject boleh nampak cuma dekat 1 meter je. Nak tunjuk berapa dia punya discrepancy, betapa very bad the vision is. Okay, so let's say at 160, at 1 meter, the patient, the subject still cannot see, then we will ask the patient to count the fingers of the examiner. Alright, so it will be recorded as counting finger at 3 feet. At 3 feet means 1 meter lah. Okay, or counting finger at 2 feet means you bring forward your finger at about 2 feet and then 1 feet. If at 1 feet tak nampak, sometimes kita akan bring lagi dekat betul-betul depan mata dia. Boleh nampak tak? Kalau nampak kita letak as counting finger close. But usually kalau dah tak nampak, kita akan terus proceed to hand movement. Okay, we wave our fingers dekat depan mata. So if they can see, then we put as hand movement. If cannot, then we'll proceed with light perception test. Okay, so for light perception test, initially we will shine right in front of the eye. Okay, let's say the patient see, or even the patient can see, kita akan buat into 4 quadrant: superior, inferior, nasal and temporal. Okay, we go to definite tempat and make sure to assess for light perception, it must be done in a dark room. Alright, so testing each quadrant, kita tanya dia nampak tak the light source. Sometimes you can, if macam the subject, the patient's giving macam vague answer, we're not sure, so you can test without giving the light. Ada tak? Kat mana? Kalau dia kata ada but you don't shine anything, you know that patient actually cannot see. He just saying that he can see. So you need to do this test lah. Okay, so shine, if can see, ask the patient to locate which is the quadrant. Okay, sometimes dia kata nampak, you are shining from the nasal, dia kata nampak, tapi bila you tanya daripada mana, the patient will say from temporal. So we know that patient tak nampak dah nasal tu. Okay, alright. If let's say tak nampak the light perception, we jot down as NPL, near perception to light. Okay, so this is the measurement of Snellen acuity from 6.6 down to NPL. Abaikan yang PR accurate and PR inaccurate ni. Okay. Okay, but even though the Snellen chart is used widely, even in KK, klinik kesihatan, semua orang guna the Snellen chart, but there are few disadvantages of the Snellen chart. Okay, the first one, the latest are not of equally legible sebab ada huruf O and E macam dia tak standard tau. And then there's non-uniform progression of letter sizes. Kalau you tengok dekat the topmost Snellen chart ada satu je huruf besar, and then bila turun ke bawah dia tak standardized. And then some Snellen chart ada 10 line, some Snellen chart ada 5 line, dia tak standard. Okay, and then there's unequal number of letter on each line. The first line ada 1, the second line ada 2, subsequently ada makin banyak, ada sampai 9. The spacing between the letters and lines also irregular. And sometimes kita kata the ability to recognize the target or letters is influenced by literacy and past experience. Maksudnya sometimes kita dapat patient macam cerdik kan, dia boleh hafal tau, dia hafal and then subsequent visit sebenarnya vision dia dah drop, tapi dia macam deny, so dia akan sebut, dia ingat, dia akan sebutlah huruf tu, so kita ingatkan the vision is good, but it's actually not. Sebab it can be influenced by literacy and past experience, and the result inaccurate, especially in those with low vision. This one inaccurate especially kalau macam patient with amblyopia, the pediatric age ke apa, sebab huruf tu kadang-kadang dia jadi macam crowded sebab daripada sikit tambah-tambah banyak, dia tak dapat nak differentiate each letter, so dia punya result is a little bit inaccurate. Okay, so what are the chart that we have? We have this Lokma ataupun Bailey-Levy chart. Okay, this is the preferred one lah by ophthalmologists and optometrists. Okay, kalau you tengok from the topmost to the downmost, semua line ada 5 letters, and then the space between each letter are standardized. And then dia punya huruf pun dia turun makin mengecil secara regular. Dia punya progression mengecil tu regular macam standard. So this is very good lah. And the grading scale makin kecil makin bagus lah kita kata. Vision acuity dia makin sharp kalau boleh baca yang bawah. And then kita ada juga this one, Rosenbaum Pocket Vision Screener. I think most of students sometimes they have this one. This is very good, in which it is precise, clear and legible. Tapi jangan confuse this one dengan larger Snellen chart. Okay, sebabnya Snellen chart, Snellen chart you test dekat 6 meter. This pocket Rosenbaum, you test dekat near vision about 14 inch daripada vision macam tu, dalam 30 cm macam tu. Tapi dia bukan test near vision. Okay, dia test distant vision, but the distance tested is using near vision. Alright? Dia ada distant equivalent kat tepi ni. Kalau you tengok, 95 dekat tepi tu dia ada distant equivalent sama dengan 2800. Okay, so 2400 semua. So you kalau nak tahu this one, you can just Google lah also 2800 is equal to 6 berapa, like perhaps 360, 160 macam tu. So looking downwards ada 2020 kan sini, dekat adalah huruf yang kecil ni. This 2020 refer to 6 vision. Okay. So at the same time juga this card sebabnya dia ada numbers, dia ada tumbling e-chart, kita boleh guna tumbling e-chart ni ataupun kita boleh guna this XOO, very simple one. Okay. And lepas tu kat sini dia ada pupil gauge. You boleh, let's say you don't know how to estimate berapa millimeter the pupil. Sometimes you see the pupil is dilated but how many centimeter, you can refer to this pupil gauge and then you put near to the patient's pupil and then you can compare. Alright. Okay, this Jagger is actually for near vision, but we don't want to talk about this. Usually this pocket Rosenbaum is for testing visual acuity in patients yang bedridden ke apa. So what most important is the distant vision first. So we do the distant vision. And together with this visual acuity, we need to know about pinhole testing. Okay, this pinhole testing is to determine whether any decrease in vision is correctable by lenses or not. So, in another words, it means kita nak tengok the patients ada refractive error ataupun tak ada. Whether the reduced in vision is because organic causes, whether it is caused by the retina, the cornea, the lens or whatsoever, ataupun it's just non-organic causes. Okay, alright. So what is the use of this pinhole? Kenapa perlu buat pinhole ni? Because this pinhole dia akan allow one light parallel betul-betul jatuh on the retina. Okay, so dia akan allow you look at the D line kat tengah tu. The D is usually yang memang akan fall betul-betul dekat retina. Sorry. Not on the retina, sorry, on the fovea. Okay. So because sometimes some patients the pupil is like 3 mm, 4 mm is slightly dilated. So in this slightly dilated pupils akan ada aberrations. So aberrations they akan cause some astigmatism whatsoever. So we don't want that phenomenon to occur. So we use this pinhole testing to abolish every aberrations. Okay, so what we get is the very nice parallel light that fall onto the fovea. Okay, this is the near visual acuity. So like I said earlier, usually done at 40 centimeter, but it can be varied from 25, 30, 35, depending on the nature of the near task of the subjects. Okay, so in patients over 40 years old, the reduced near visual acuity is one of the symptoms of presbyopia. Alright. So you can have a look at this near acuity chart, the Jagger chart. Boleh minta dekat klinik. You can ask our optometrist, nak tengok near chart boleh tak? Okay, so kita akan suruh patient pegang dekat the most comfortable near distance, and then kita akan suruh dia baca which line yang they can read lah, and then we can add in the power for the near visions accordingly. Okay, the other things is the same. The room that is used to do this near vision must be brightly illuminated, and then patients is also asked from the chart that is bigger print to smaller print. Okay, and then but the documentation is different. It's not like 6/6, 6/9. It is N refer to the near, and then the 12/6 refer to the point size yang the patients can read. So decreased near visual acuity may be due to central cataract or presbyopia, or those with apa nama dia, already had intraocular lens implantation without the natural lens. Okay, so what about visual acuity in special group? Okay, kita nak habis dah ni. So in special group means in illiterate patients that tak kenal huruf ataupun children less than 5 years old yang tak cooperative. We have a few testing. So we have this illiterate e-cutout test, tumbling e-test, isolated hand figure test, and then Sheridan Gardner. This Sheridan Gardner kita ada dekat klinik. So you can have a look and pictorial vision chart. The broken wheel both can be, and like home we don't have it. Alright, vision test in 2 to 3 years old, usually we use dot visual acuity test and miniature toy test lah. In 1 to 2 years old, this is the preferred one: marble game, Sheridan ball, bird candy, worth ivory ball test. But apart from this also, we have preferential looking test. Okay, I will tell you about the preferential looking test after this. So the visual acuity testing in infants. Infants means less than 1 year old. Maksudnya dia macam dah lah susah nak cooperate, tak faham arahan lagi semua kan. So we have this OKN, which is optokinetic nystagmus test. Alright, so this OKN is actually using this drum. Okay, so kita akan tengok the nystagmus. Okay, so the interpretation is a little bit different. So you can go to later, anybody go to the clinic if you all boleh masuk klinik later dekat pediatric attachment. So you all boleh ask the registrar or the MO about this OKN drum, and they will show you how to do it and how do we interpret. And then we have this preferential looking test. Preferential looking test means okay, you all tengok dekat gambar ni yang the mother hold the baby, and then one the doctors holding the cut. So one area is kosong, tak ada apa-apa. The other area yang ada gratings. Okay, so if kita tengok pada children punya the baby punya respon. Because if the baby has good vision, dia akan fokus pada the part yang ada gratings. If let's say the vision is poor atau tak ada, the mata akan just wandering sebab dia tak nampak apa-apa pun kat depan. It's just the same. Okay, and then other than that, other than using this, kita boleh guna yang gambar lah. Gambar means dalam bentuk burung, ada rumah apa semua. Yang tu pun how do we know the vision whether it is 6/6/6/12? Kita ada reference dekat kad ni. Okay, if let's say the child respond to this preferential looking test dekat kad 6/12, so the vision is 6/12 macam tu. Alright, then we have Catford drum test. Catford drum is lebih kurang macam OKN drum tapi ada gambar-gambar. And then we have this Cardiff Acuity card test. Okay, this one ada dekat klinik. You guys boleh tengok juga. And other than that, adalah special test which include visual evoke response and teller acuity cards. And other than that, indirect assessment of visual acuity. This indirect assessment of visual acuity, which is blink reflect or menace reflect, we use this one to assess the potential vision of the baby or infants in ICU. I mean like, you know, like patient whether intubated ataupun because of whatever problem, you can't bring the patients to the clinic. So we do this test. How do we check blink reflex? Okay, we can test for because blinking, the corneal, we are testing the fifth cranial nerve. So we can use like cotton yang kita haluskan, kita test the corneal reflex. Kita touch on the cornea. So if the blinking ada masa tu, the fifth is okay juga. The fifth is okay. Other than that, this menace reflex, macam you tepuk tangan ataupun you threaten the baby. So if dia boleh nampak dia you punya gerak tangan ataupun dia boleh rasa, because if you tepuk ke apa kan macam ada air pergi ke mata dia, okay, dia akan blink. Alright, if patient blink, other than that boleh suluhkan lampu, bright light. Okay, if using all this, the baby respond, so we can say that this baby ada vision. But berapa kita tak tahu, but we can say there is some vision. Alright, so what about test based on fixation reflex? This is monocular. We do monocular and binocular. So monocular is the central study and maintain method of rating monocular vision. This one adalah lebih pada masih kita buat refraction lah. So the binocular vision means we are testing two eyes together. Okay, this one, the standard fixation preference testing and vertical prism test, we do it in patient with screen. Okay, because we need to test first monocular and then binocular. Okay, kita nak tengok ada preference ataupun ada we want to know if like dua-dua mata ada screen, we want to know dia ada preference tak using one eye. Okay, because if the screen, if the patient's having bilateral screen, and then dia ada preference, let's say prefer to use right eye, so we know the right eye vision will be good and left eye vision will be poor, so the poor eye will end up with amblyopia. Okay, that's why we need to do this test. Okay, this is tumbling E test, means using letter E, that is turun terbalik, so kita akan test one by one macam tu lah. Okay, and then this is the Sheridan Gardner using 4 letter HOTV. Alright, and the last one is Landau test C, Landau C later. So kenapa? Sebab each procuring subtends an angle of 5 minute. 5 minit ni daripada atas sampai bawah. So the one yang open up is 1 minute of arc. Kalau you ingat awal tadi, I ada kata the Snellen chart punya basis is assessment of the 1 minute of arc angle dekat nodal point. Alright. This is visual evoke response, in which kita akan put electrode lah on the scalp to look at the electrical signal from the visual cortex. Okay, let's say we don't know the vision, let's say patient with cerebral palsy, ataupun we want to know the prognosis, and then we can do this because we can diagnose the like cerebral visual impairment. We have the CVI, not only CVA, we have cerebral vascular accident, we also have CVI, which is cerebral visual impairment. So if let's say patient with CVI, we know the vision is not correctable. So whatever you do, whether giving glasses, do cataract surgery or contact lenses, the vision will be the same because the impact is on the cerebral level. Okay, so I finished my lecture. Do you have any questions? I think some of you already had the this visual acuity class yesterday, right? The practical. Oh yeah, sorry. This week only lectures, right? Okay, alright. So, okay, tak apa. Because we don't know the situation yet, we will see. Because it's good if you can practice how to test this visual acuity. And later, if you guys ada the practical sessions, for visual acuity, you need to know how to do it and how to document it. Dan nanti bila you assess, you akan nampak lah. Let's say, kejap I tunjuk dekat share screen. Okay, let's say tengok sini kan. Kalau kita test dekat patient, patients can read 618 semua, and then bila kita, sebab dia kan read daripada besar ke kecil, so 618 patients can read all, and then at 612 perhaps patient can only read HU. After that dia kata tak nampak. Okay, how do you document it? It's not only 612. If you write 612, mean patient can see semua ni. So if let's say patient can only see HU, you can write as 618 plus 2. So orang yang tengok, any oftal yang tengok, dia akan faham that patient boleh tengok 618 line plus 2 letters daripada 612. Alright. So let's say kalau lah dia boleh baca, kita pergi bawah sikit. Contoh dia boleh baca dekat 69 and then baca dekat 66, dia boleh baca TYHMI, which is 5 huruf daripada 7 huruf dekat 66. Dia dah lebih separuh kan. So macam tadi I kata, you boleh letak 69 plus berapa dia boleh baca dekat yang bawah. Tapi sebab dia 5, dia dah lebih separuh daripada dekat 66 line, so we don't do it. Kita akan letak 66 minus 2. So dekat 66 line, dia tak boleh baca 2 huruf. Faham tak?
Faham Doktor.
Faham Dok.
Okay, alright. So this is the one yang you akan buat lah. Because in real patient pun you akan jumpa macam ni. Selalunya diorang, yelah most of them boleh baca penuh-penuh, tapi those yang with visual problem for whatever reason, nanti you akan dapat yang dia boleh baca 1 huruf sahaja daripada line tu, 2 huruf, atau kadang-kadang dah banyak, tiba-tiba ada 1-2 huruf dia tak boleh baca. So we use plus ataupun minus beberapa huruf kat belakang tu. Okay. Alright. Tak ada question ke? Tanyalah apa-apa.
Assalamualaikum Doktor.
Waalaikumsalam.
Can I ask, kan kita kan selalu guna Snellen chart, but why we don't use the logma chart?
Because logma chart, kita perlukan, logma chart ni memang dia guna projector. So because it's not printed, dia tak ada yang version yang printed, and then dia guna projector, dia dan the harga untuk logma tu is little bit expensive. If Snellen chart, kita ada Snellen box ataupun chart yang besar di print, that one is much cheaper and easy to be like place everywhere. I mean, kalau dekat klinik kesihatan dia boleh tampal terus kat dinding and then dia boleh arrange terus. Okay, 6 meter difference jarak macam mana semua. Atau kalau dia pakai the Snellen chart box pun senang, dia boleh cari one dedicated place. But with 6 meter difference macam tu, dia boleh selit je kat mana. But for Bailey-Levy chart, satu, the harga is slightly expensive, and then this one sebab dia dekat, biasanya dia dalam integrated system tau, yang ada assessing the other things. Kalau you datang dekat klinik mata, you boleh tengok our chart tu. Kalau kita buat refraction dekat patient, kita boleh suruh dia baca that chart, and then kita akan proceed with testing dia punya power. So kita boleh tengok dia punya dia ada beberapa test lah, duochrome test, details, dia sangat details. So it's not being used outside sebab the system tu a little bit complex. Dekat klinik kita still guna Snellen chart. Snellen chart is the one yang staff nurse dengan kita punya PPK akan buat lah. By the time patient datang, kita still akan buat Snellen chart je dulu. Okay, let's say kita nak details, nak buat refraction, then only akan masuk room for refraction tu, kita akan guna Bailey-Levy chart. And this Bailey-Levy chart, dia punya bagus sikit sebab ni kita boleh pilih pada satu huruf sahaja. Jadi patient with amblyopia, kita akan guna satu huruf, daripada 660 tu kita test ke bawah dengan guna satu huruf sahaja. Sebab tu patient-patient yang ada complicated cases, kita akan suruh refer to ophthalmic clinic because we have other options, we have other way to test. I
Thank
answer
you,
the
Doktor.
question. Ah.
Yes, Doktor. Thank you.
Okay, any other
Doktor,
question? Ya?
saya nak tanya, kan sometimes we have the the compact snellen chart yang kecil tu macam pocket snellen chart tu kan.
Ah.
So for that snellen chart we use hand length kan, satu tangan kan.
Arm length.
Arm length kan, doktor. So kalau patient tak nampak, kita kena gerak ke depan lagi ke benda tu? Macam snellen chart yang besar ke tak perlu?
Okay, that's why kalau you guna yang reduced Snellen chart, sebab banyak yang printed version, so the reduced Snellen chart you kena tengok. Kalau yang proper one, let's say those yang beli dekat Kamal ke apa, dia akan tulis kat situ nak test dekat which distance. Okay, sebabnya in order to reduce the Snellen chart, untuk buat dekat near vision, untuk dekat 1 arm length ataupun 30 cm macam tu, dia kena ada the conversion lah, berapa akan mengecil tulisan tu. So you akan kena properly guna. Kalau let's say dah tak nampak lah. You cannot bring forward. Sebab kalau you bring forward, dia punya, you punya finding tu dia dah tak tepat. So macam yang I tunjuk tadi, yang Rosenbaum pocket, kita buat dekat 14 inch. 14 inch, 14 times 2.5, macam about 30 cm kan. So we test dekat 30 cm lah. 30 cm satu pembaris panjang tu kan. Jarak satu pembaris panjang. Kita suruh dia read dekat situ lah. So kalau dia tak nampak, then kita seberapa yang dia nampak lah. Okay, kalau tak nampak, at least you boleh guna you punya jari. Like we always use our jari, do dekat 160, dekat 1 meter distance. Kalau patient can see our jari dekat 1 meter, so minimum is 160 kan division. So you go jauh sikit. Kalau you pergi jauh sikit, dekat 2 meter dia boleh nampak lagi you punya jari. So you know the vision is better. So oftal kadang-kadang kita akan tulis kalau kita tak dapat, let's say dia tak dapat nak baca proper yang reduced Snellen chart atau the Rosenbaum pocket, kita akan check with the counting finger and then kita akan tulis visual acuity at least 260, at least 360. So that one understood sebenarnya the assessor is using the finger, tapi suruh patient count finger dekat jarak yang jauh sikit sebab kita tak bawa chart pergi jalan ke patient. So we are using whatever we have. So our fingers is macam the most useful tool lah untuk oftal sebenarnya.
Thank you, doktor.
Doktor nak tanya, tadi kan yang regarding Snellen chart tu, doktor kata kalau dia dah lebih half of that line, so kita ambil yang latest kan, macam yang 6 tadi, walaupun dia tak habis but dia dah macam sampai 4 sampai 5, so kita ambil yang latest. Tapi kalau macam dia dekat line 6/18 tu kan doktor, kan ada 4 letters. Kalau dia boleh betul 2 je, lepas tu 2 lagi tak boleh jawab, so kita ambil 6/18 ke 6/24 plus tu doktor?
I akan ambil the better one. So kalau dekat 6/18 dia boleh baca 2 letters je kan, tapi dia macam half. So I letak 6/18 plus 6/18 minus 2. So orang tengok dia macam nak cakap, kalau you tulis as 6/24 minus 2, kat situ macam nampak 6/24 tu yang macam lebih besar, kata alamak punya vision dia. So you put as, sebab dia half. So half you boleh guna yang besar sikit atau yang kecil. So we all prefer you tulis yang the better one, 6/18. So we know that 6/18 minus 2. So dia boleh baca dekat level 6/18 tu dah. Alright.
Betul, thank you.
Okay. And then every vision kita akan buat dengan first without the pinhole. Okay, so without pinhole, let's say the vision is 6/24 minus 2 contohlah. And then you buat with pinhole, the vision improve to 6/9 plus 2. You akan tulis macam tu tau. So document you first VA ataupun vision right eye, VRE, tulis 6/24. Lepas tu sebelah tu tulis PH, pinhole berapa. 6/9 plus 2. Macam tu lah. The documentation kena ada yang without pinhole and after pinhole. But let's say bila you buat vision tu dah macam like 6 just -2 macam tu, sometimes we don't bother doing the pinhole lah. Sebab we know dia ada sikit refractive error, but either way dia memang dah boleh baca 6. But if for practice, it's good to do, let's say dia 6 -2, boleh buat pinhole 6. Atau perhaps sometimes patient dapat 6-5. Macam tu. So itulah. 6-5 I tak covers because this 6-5, 6-4 dia macam division is very very good. Kita tak kacau lah. Kita nak stop dekat 6-6 je because 6-6 is the standard yang everybody should achieve. Okay, kejap. And then to assess the visual acuity juga, let's say the patient come to you with glasses. And then they complain poor vision, jangan take out the glasses. We need to assess with the glasses on. But kita akan terus kat situ, contoh vision right eye. So vision right eye itu dalam kurungan aided ataupun with glasses. So we know that patient memang ada glasses and then you are testing with the glasses on. If let's say patient tu datang dengan poor vision, dia kata dia ada pakai cermin mata tapi dia tak bawa, so you tulis sebab you tahu dia pakai cermin mata dia tak bawa. Lepas tu pula dia kata poor vision, so you kena tulis like vision right eye dalam kurungan unaided. Unaided berapa, pinhole berapa. So next time bila dia datang, kita akan pesan kepada dia untuk bawa glasses. So kita akan tulis pula aided berapa. Okay. Clear tak so far?
Doktor.
Yeah? Okay. So any other questions? Okay, because you guys ada macam like our numbers, I think some of you pun diorang dah appoint kan siapa yang jadi you punya supervisor. Kalau ada tu, you all boleh contact kalau ada soalan ke, permasalahan ke, apa semua. So, use this time. Maksudnya macam even though the learning currently macam kita terpaksa buat online balik semua, but you still can ask the lecturers. Maybe kalau the lecturer tak reply terus ke apa, tak apa, tunggu dulu, the lecturer will reply afterwards usually. Okay, sebab some of prof apa semua, they will be a bit busy. Alright, any more questions? Tak ada. Okay, alright. Kalau tak ada questions, maybe we can end the session now. And then you can prepare lah for the next lecture later at 11:30. Okay, alright. Thank you very much for your cooperation.
Thank you, Doktor.
Thank you, Dr.